Welcome to the Brain and Body podcast with Allegra Foxlie, where we discuss a holistic approach to healing and health. Hello everyone, I'm Allegra, a trauma-informed bodyworker who's passionate about helping people to recover from challenging times. Today, I'm absolutely thrilled to welcome Dr. Hector Rodriguez, a psychiatrist based in Miami, where he works with the renowned Dr. Daniel Amen, a pioneer in brain health and imaging. Dr. Rodriguez specializes in analyzing SPECT scans to uncover the unique patterns associated with trauma and mental health conditions. But before embarking on his journey into psychiatry, had an entirely different career as a fashion photographer. So I'm so curious to find out about his journey. Dr. Rodriguez, thank you so much for coming on the podcast. How are you?
Oh, good. Thank you for having me.
Oh, my pleasure. My pleasure. I wanted to do this podcast with you ages ago, but I appreciate that your schedule is pretty manic. And the fact that you are based in Miami, the time difference can be a little bit tricky because I'm in dark, cold winter, wishing I was in Miami. Do you want to tell the listeners about your journey and how you became what you are today and why you are interested in this area?
Yeah, I agree with you. I think where we go and where we're coming from, I think says a lot about who we are. And it builds and enriches. I mean, I really have to thank putting that in my head by my parents. They were always very much visionaries and in their own way. They just didn't think that was what was going to really push me today to do all the things that I've been able to do in my life so far. So, but going back, I mean, I was a fashion photographer for about 10 years.
Amazing.
I didn't want to go into medicine yet. I've been much, passionate about art. And anyone that knows me knows that I'm always trying new techniques and different things. But the cool thing about photography and how I got to psychiatry, and then today what I tell people, I take pictures of people's brains.
Yeah.
I just don't take pictures of their exterior anymore. But it's just really cool. I mean, I remember I would have long photo shoots and I would spend most of the time talking to the models, getting to know them before they get in front of my camera. So it was kind of my way of getting to know them, getting them to trust me. But I didn't think that what I was really doing was mental health. A lot of these models were going through their own personal struggles. So we would kind of use that time to bond. But I mean, it's just really cool how from there, I became really just passionate about working with people in a different way. And then, finished medical schools, did residency and all that. And then I discovered SPECT imaging through Dr. Amen. And he really just put a little spark in me to join the team to revolutionize mental health. And it really should be about brain health. So that really just changed the way that I see people's behaviors, the way that I see, one of the things that I always remember him telling me is, there's no bad people or there's no, dumb or stupid or those labels that we give people. It's their brain is not working as it should. So then tying it to trauma and just life stressors, we see patterns in the brain scans, which is fascinating.
Well, there's a few different things that have come up for me there, right? So mental health, I completely agree with you. I think there's such a stigma around mental health, and it annoys me because it shouldn't be like that.
Mm-hmm. Big time.
So I do think brain health is much better. It's a much better term. What is a brain SPECT scan?
Right. So a SPECT scan is, it's a blood flow study. What Dr. Amen did, probably over 35 years ago, was use this method of seeing an organ, but through function, through activity. Yeah. So what we do is, we'll do 2 different scans. The SPECT scan allows us to see what parts of the brain are hyperactive, especially in the emotional. That's really where all the trauma is kind of, I tell my patients, kind of recorded. But then there's the cortex, which is what we call our thinking brain. And if you ever go online and look up our SPECT studies, that's the colorful bubblegum looking one, where I tend to prefer the emotional one, which is the blue and like pink and white one. Right. So what it does, it picks up the tracer and it tells us where there is more or less activity.
Okay. And so for the emotional brain, you're talking about the more limbic. Right? So the amygdala, the fight or flight, just the listeners that don't understand the different parts of the brain. What is the difference between someone that has grown up with love and has had no adverse childhood experiences, no real stresses, no bullying or anything like that, in comparison to someone that has had challenging times?
There is a dramatic difference between people who've experienced childhood stressors versus people that have not. And really the main difference is that what we call the diamond pattern. And it lights up in the scan like the shape of a diamond. And that's usually seen in psychological and emotional abuse. Sometimes our patients don't remember it. Sometimes our patients, have a trauma blocked. But when we see that, immediately I'm like, okay, we got to focus all of our efforts and everything on what's going on with this diamond pattern. What caused that? Now, at the time of the evaluation, it's not my job to do that. And I strongly advise them, don't go home and start going through your memory database, seeing what did that. No. Don't do that. But
that's
it does.
Pandora's box, isn't it?
Yes. Do not open Pandora's box, because anything can come out. And that's what I tell them. I'm like, trauma is like Pandora's box. So a lot of the patients that I do get that come to us, first of all, they've been through an average, I think Dr. Raymond has said about 4 to 5 psychiatrists. So when they come to us, they really have had every single diagnosis in the DSM-5. And that's what I tell some of my colleagues, like, I can smell PTSD here because they have 5 or 6 other diagnoses and no one has thought of PTSD.
Yeah. And have those psychiatrists, I'm just curious to find out, are they specialists in trauma? Because I appreciate some psychiatrists, they can be quite generalist, can't they? If they're not focused on that day in, day out, because I don't want to put psychiatrists down. But
no.
I say to my clients and to my friends and to everyone, choose your therapist, right? But your therapist has to be a specialist in your area. Mm-hmm. And I think if you're not a specialist, then we see misdiagnosis day in, day out.
Yeah, and I do see a lot of that. I see a lot of misdiagnosis. But I mean, I agree. I think going to the specialist in your area, but then it's like, how do we know unless you look?
Yeah. Like
if the patient doesn't come and tell you as a psychiatrist, I don't have these, traditional PTSD symptoms. I have all these other ones. Like, that's why I call it a Pandora's box. You have a little bit of psychosis, a little bit of dissociation, a little bit of emotional, a little bit, they look bipolar, so that they'll come with all these diagnoses. And I'm like, no, wait. Let's look at the scan. And what is the scan telling us?
Yeah.
You have many patterns that are telling me you experience stressors. You just don't remember them. So that's why, to me, as a trauma expert, the SPECT has just revolutionized even how you can look at trauma. I think a lot of us experience stressors. Not everyone knows how to cope with them. Not everyone later has the resilience to go through them. There's so many other factors there. Like, cause then you start thinking, how come people develop traditional, I call it traditional, PTSD symptoms, and some don't. So they get misdiagnosed, but they still experience a traumatic event or events.
Yeah.
So then it's like, how do you know? Well, that's why I go to the SPECT scan. So a lot of the patients that I have, once I show them the SPECT scan and I show them the patterns, I really just shift their focus, because now they're like, wait, I never thought about that.
Yeah.
You didn't, you blocked it.
Yeah. Yeah. Because your brain has been in protective mode. Thinking there's a tiger in the room it needs to protect you from. So it's action stations all the way.
And then, you'll see that they'll be given multiple medications, nothing works. They've done other kinds of therapies that are not trauma focused. It doesn't work. So then you're like, okay, so we're missing something. There's a few psychiatrists that I have at least dealt with that do say, okay, no, I'm missing something here.
Yeah.
And they either refer them to us or we collaborate together on some cases, but there are some that just don't. So yeah, I'm not into, talking negative about, but I do agree. For example, Dr. Amos always telling us, like, you have to read.
Yeah.
You have to prepare yourself. You have to know, even as a psychiatrist, you finish your training, but you have to keep understanding what's going on with this beautiful organic organ.
You have to be hungry and curious.
Yeah.
Do you know what I mean? Because I'm like a kid in a candy shop with all of this stuff. I'm like, oh God, that's really interesting. And then it will take me on a completely different route. I'm like, but what does this mean? So yeah, I do find it incredible. Gabor Mate, I think he said that, you can have people with capital T trauma. And for the listeners, right, capital T would be car crash, a sexual attack, earthquake, something major. And the ones that go on to get PTSD, this is his opinion, not mine, but it might actually tie in with what you've just said, are the ones that had adverse childhood experiences, whose nervous systems were dysregulated, unknowingly dysregulated before that event happened.
Yep.
And then the nervous system has been pushed to a certain point, like an elastic band, of kind of a difficult return, but you can have that return.
Yep. Yeah. I always, when I worked with some people that just don't remember, and then we take a few minutes to, well, let's just think about our childhood. Was there any moment in time that you just don't remember? They're like, yeah, I don't have memory from when I was 8 until I was 14. I'm like, you should have some memories at that age. Some. You have no recollection of anything that you did during that time period. And then the parent is there, and that's where the stigma just melts off, which is amazing, because then the parent just changes their body posture and everything. I can tell they know something. Yeah. And I stop them. I'm like, don't disclose that, because I can tell that something came into your your presence,
back
right?
To you, yeah.
Yeah. So it's like, don't do that. Let's go to the therapy to work that through, because there was something there for sure. So going back to what you said about once the nervous system is ready for that tiger to attack, it's always going to be on high alert. Yeah. So any other stressor, even after a big T trauma or a little T trauma, the body is kind of prepared for that. So then when they do experience even a small T trauma, they react like the big T trauma is coming at them.
Yeah.
So
they're
this particular
more reactive, aren't they?
Yeah, very, very, very. So a whole array of symptoms come out. This week in particular, I had several cases. Most of them were young males that just became, after a certain time, they'd stopped speaking, right? They were so stressed out and stopped speaking, losing their hair. So they obviously had all the whole full medical workup, what's going on with the speech, what's going on with the loss of hair, and, you do a hormonal workup, all the works. So then we go to the scan and we see the diamond pattern, and I'm like, well, what stressors do we have prior to change of behavior?
And
mom starts remembering, we moved to the US. He had a huge fallout with his dad. Well, those are stressors. Oh, and now that I think about it, we were in a major car accident when he was 5, where his dad was almost, was close to dying.
Yeah.
So that was probably his big T trauma. Now we have other traumas. Because how many people migrate? Many people migrate. People just don't change behavior and lose their voice after moving to another country. So he had another stressor.
And it builds and builds and builds like a pyramid. It's like a sand pyramid.
Yeah.
And you can build it and build it and build it, and then it's absolutely fine. But then one thing can cause a catastrophic avalanche.
Big time. And unfortunately, sometimes when that avalanche happens is a whole array of symptoms where then the patient gets diagnosed with schizophrenia, with bipolar. And you're like, wait, hold on. Let's really go back and reevaluate what's going on here.
Well, let's talk about those symptoms, actually. So for the listeners, what symptoms do you tend to see? Because I know that there'll be cognitive, there'll be emotional, but there'll also be physical as well.
Yeah. A lot of the physical ones are, we see it when there is hyperactive thalamus. Thalamus, think of it as the relay center for the senses. So pain is one of them. So they can have lots of pains. They'll get diagnosed with fibromyalgia. And you're like, lots of gut issues. So we see an inflammatory response in a lot of these people too. And then you see on the surface scan what we call scalloping. So it looks like inflammation, toxins.
Okay.
So you're like, okay, what's going on here? They tend to have a hyperactive immune system.
Right.
And there is actual immune cells that only show up in people who experience traumatic events. So it's the body's way of trying to protect itself from danger.
And what
So there's
type of
always
immune cells
inflammatory.
are they?
They're CD4s.
Okay.
Mm-hmm. So it's like it creates this hyperactive immune system. Sometimes you can have thyroid disease because you have antibodies against the thyroid. So then you have a whole other array. I do tend to see a lot of just autoimmune conditions. Going back to the symptoms, problems with just regulation of their mood.
That's a big one.
Yeah, that's a big one. They can't control it. Physical, we also see, like I said, loss of hair. We see a lot of skin conditions, which tends to be just a hyperactive, immune system. Yeah. So when you start coupling a lot of those with the neuropsychiatric symptoms, there's the mood dysregulation, there's the problems with focus, concentration, and then they're given ADHD medication and then they're worsened. You're like, okay, no, this is not ADHD. This brain's limbic system is on overdrive. So don't give it a stimulant. It's going to get worse.
And it's so interesting because I know, I know quite a few people with ADHD, but some I've said to them, I was like, no, they're friends. I'm like, your issue, what you're struggling with is not ADHD. You don't have it as far as I'm aware. Your issue is trauma and you need to address it.
Mm-hmm. And a lot of those people don't think that that's the case. So then when my treatment is not ADHD focused, they're looking at me like, this guy knows what he's talking about. And I'm like, just do it. And then they come back and like, oh, my focus is so much better. Yeah, we calm down your thoughts, with your worries, your ruminations. That's what was getting you, not being able to focus. And then you look at our world today, we're hyperstimulated. So much sensory information thrown at us.
I mean, I struggle with it on Instagram because, obviously we have to post on Instagram, don't we?
Right.
And then you can get, again, sucked down the rabbit hole. And, an hour later, you'll be like, just completely wasted my time. But we are bombarded with stuff. You can't escape it. It's on your phone. Yeah. It's on your laptop. On TV.
Yep.
It's everywhere.
And it's that hyperstimulus that sometimes can create the brain to think that we need to fight or flight. But no one is really talking about that. And that's one of the things that I always tell a lot of my patients, like, listen, if you just put yourself away and chill for a weekend, you're going to see how your focus just improves. You're overstimulated. We need to simplify some things.
Yeah, I had Susie Diamond Kane on the other day, and she has ADHD. She's trauma informed, and she helps people recover from narcissistic abuse. And she said that when she was doing her master's, she actually did it on social media and the impact on the brain. And that was quite a few years ago. And her prediction was that it was going to cause huge problems, and that a week or two away from it would be much better. And now I see that Australia, they're actually putting through a ban, aren't they? Mobile phones and social media. Because it's affecting everyone's neurobiology.
Mm-hmm. And there is neuroplasticity. And I think, when you start changing a lot of those networks, it's not always for the best. I mean, we see it with trauma. So what we try to do when we're working with our trauma survivors is let's use that same physiology to rewire the brain back to feeling at ease, feeling peaceful. But the same thing can happen then at the same time, this process that is working alongside against us, because then we're hyperstimulating the brain again when the patient leaves therapy. And you're like, it's a struggle.
Yeah, I think it is difficult. Just going into the misdiagnosis again.
Yeah.
So can you explain just a little bit more about the difference between ADHD and trauma and why it gets misdiagnosed all the time?
Yeah. The main thing that I notice, that it gets misdiagnosed is just when people come in saying they're complaining of inattention. And then if the clinician just kind of gets stuck on that, they're biased by the information the patient's providing. So you still have to stand back and look at, okay, what else could be going on? Don't just go by what the symptoms the patient is telling me. So honestly, one of the biggest difference tools that I use is the SPECT scan. Yeah. Because a person with ADHD, you would not see so much limbic activity, although there is a type of ADHD that is limbic. But in my opinion, a lot of that has to do with stressors that person experienced. So they do share very similar things, but other things like dissociation, things like mood dysregulation, things like a lot of the physical symptoms of distress, an ADHD individual won't have that. What can get more complicated is when the person with ADHD experiences traumatic events.
Which is common.
Which is pretty common. Yeah.
I think they say that people with ADHD, if you're a child with ADHD, your chances of being diagnosed with PTSD as an adult are 4 times higher than if you don't have ADHD, because they are discriminated systemically, by the government, by education, and all sorts of different things, which means that they will endure more stress.
Yeah. And I mean, and I see a lot of people from Latin America. So whenever they, it's different, I think, how the rest of the world sees ADHD. I think now some people, at least I've seen it a lot on social media, and I'm like, what's going on here? They are seeing ADHD as kind of like, oh, that's cool to have. Like, it's cool to have. Where in Latin America, it's like, no, my child is not dumb. I'm like, we're not saying that. We're saying he has a problem with concentration and focus. They're not dumb. We're not saying that. So that it's this dichotomy thing that happens when I have those two types of patients sometimes in front of me. And they take a long time to figure out what is truly happening to their child. But that's one of the things that I see on a day-to-day, is they're very much discriminated against. But when I see it, is they see it as the tag of I'm stupid. And it's like, no. You have an inattention problem. We gotta shift how your brain focuses. That's all.
Yeah. Because all the people that I know who've got ADHD are so creative. Many of them are also dyslexic. but they're really creative and usually quite entrepreneurial. So
Mhm.
it's just about actually guiding them to the right, as with any neurodivergence, right?
Right. Exactly. And that's the same thing that I tell my patients. And they, there's another part of our brain called the cingulate gyrus that allows us to kind of shift our attention. So sometimes when that is working too hard, we have a hard time shifting it. So then that can happen too, where people get stuck on something. So you hear I'm hyper focused
Yeah.
on something, right? That I'm passionate about. So then I tell them, okay, let's learn to shift that and know when to shift it, because your brain actually does that. We do a whole treatment plan on that to help them do it. But I always tell the parents, like, use that as a positive tool, because then that child can like just thrive if you just help them shift on what they're passionate about. We got to find what I call the carrot. You got to dangle the carrot and you're going to send them in the right direction. But it's a challenge for some of that.
Yeah, that does make sense. And it's interesting when you say how different cultures view labels. I went to Dr. Rachel Garrett. She's worked with Doc Amen before. She set up a charity in London to help people get private diagnosis really quickly, and she funds it basically for anyone that's struggling with neurodivergence. And I listened to several people talk, and I think the running theme was, and all of them had ADHD, some neuroscientists, etc. The running theme was the term, the fact that it's got disorder at the end of it. And I'll put this as well with post-traumatic stress disorder. I know there's a push at the moment, isn't there, for the DSM-5 to change the name to post-traumatic injury, because I think the feeling is that a lot of people in the army aren't actually seeking help for post-traumatic stress because they view it as a disorder and they think that potentially it's their fault and there's something wrong with them when it's not. So by calling it an injury is different. And ADHD, we should just get rid of the disorder. Element.
Yeah.
What do you think?
The term disorder is definitely has caused a lot of controversy. But then I think, like, when I think of disorder, I focus more on distress. So because then when I do think of the word injury, I think more of a physical injury. And there is sometimes evident on the SPECT scans, for example, of physical injury. So that when I'm explaining that to the patient, I'm like, this is a physical injury, what we're seeing here. Over here, we're seeing an emotional assault. So I use words like that: an emotional assault, an emotional dysregulation, an emotional distress. So, because then you go in a step further and look at the word like gender dysphoria, right? I tell them, like, we got to focus on the distress part of it, right? If it's not causing distress, or if it's not causing problems in other areas of your life, then it's not a disorder or a distress. So then there's no diagnosis necessary. Does that make sense? So I think when you look at the DSM-5, first of all, is it's a really old method of diagnosing based on clusters of symptoms. And that I definitely agree with Dr. Amen. I think we need to, in psychiatry, advance ourselves. And our science has advanced enough to use other tools like SPECT, and there's other ones too, that is not just based on symptoms, but more on, what is the organ actually doing, and what has it been, what has been done to it, whether it's emotional or physical trauma to the brain. So all that to say is, when you look at these words, like disorder, I always at least start to tell my patients, has these things, these feelings, these emotions, your behaviors, have they affected these other parts of your life, of your functioning? No. So then there's no disorder. Now, then you start looking at other kinds of diagnoses that the person perceives it as has not caused any problems, but then everyone around them says, yes, it has messed up relationship. It has, because you mentioned narcissists before, they're completely oblivious that there is a a problem.
It's everyone else around them. And
Everyone else around them.
And everyone else around them questions whether they're a narcissist. It's like, am I a narcissist? Is it me?
Right.
Like, am I going crazy?
Yeah. And so, you start thinking about choosing what words to say. You got to think about all those other ones too that are in that same DSM. But then you start questioning the DSM.
Yeah.
And I think that's been happening for a while. And I think obviously we have, there's pushback, and because it's, you think about it, it's like, what is it? Psychiatry Bible that we follow. So it's like, when you start questioning that, you're like, okay, what are we doing? And then we don't want to cause a disorder within the system that then we don't know at least what to go by.
And is it, sorry, I've just cut you off. What were you going to say?
No, you're good.
And is it,
no.
Does the DSM really take into account the difference between the female brain and the male brain?
Exactly.
Because the symptoms can be different. And women are much better at masking things.
Very different.
For example. So often they will get diagnosed a lot later.
Mm-hmm.
And actually their symptoms can be quite different.
Yeah. What I have seen is women are really good, maybe not masking, or maybe the clinicians are not good at seeing those symptoms in females, which are more cognitive or frontal lobe symptoms. Because again, we're traditionally seen as males are more frontal, females are more limbic. So then we kind of tag every limbic kind of, illness as that's a female. But then you also misdiagnose males that have depression, anxiety, bipolar, borderline, because they're viewing it as, but it's a bias. Yeah. So then you're like, okay, so then what do I use to properly diagnose? And I think that's the revolutionary approach that Dr. Amen has been, doing for many years, is we have to look at what the organ is doing, not just what the patient is feeling and actually help those areas. But that means we have to educate ourselves on the actual functions of all these areas of our brain.
Yeah.
That as psychiatrists, we're not trained that way. We're trained to follow these symptoms, these check boxes. This is your diagnosis. This is your treatment plan. Go.
Which seems ludicrous.
Right.
Because if you've got someone, and they go to a psychiatrist and they go, I've got this.
Mm-hmm.
Number one, they could be delusional.
Right.
And they might not have that. Right. Or they could be a liar. There's so many different external kind of things that could mean that a misdiagnosis is probably
possible.
Quite easy to. Yeah, of course.
Very possible.
So about getting the right diagnosis and the fact that you do brain scans, it just seems like common sense. Why isn't everyone doing this?
Right. Exactly. Why isn't everyone? And I think, in my opinion, many ways to answer that. And again, coming from as an adult, I worked in a whole different field. And then now as an adult, I'm working in this field. There is something that they both have in common. The photographer and the doctor is they have this, I know it all. I should be able to determine XYZ. I don't need this other thing to diagnose someone. And I completely disagree. Cardiologists, they use many imaging techniques, electrodes to see what the heart is actually doing. Every other specialty does. Why are we not?
Yeah.
In my opinion, we're treating the most important organ. If this organ is gone, everything else is shut down.
It's the foundation of emotional, physical, psychological, everything.
Your person, who you are,
Yes.
So
yourself.
When you look at that, I think there's a little bit of that touching the ego of I don't need this other thing to tell me what to diagnose or give my patient. And I disagree, strongly. And then I think there's the other part of they're just not reading, that we're not learning. We're not in residency. We're not taught these brain functions. It's just like, okay, it's there. And this is this more like just anatomical, but not how they each affect certain functions that create symptoms if there's something wrong with them. And then the other part is how they communicate with each other. And that's where those patterns come in. Because when they communicate with each other, it's a whole other world that opens up to understand what the brain is doing.
Well, it's so interesting, isn't it, about that communication? Because I remember when I had really major PTSD, nightmares, and, tick, 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 everything.
Mm-hmm.
My brain, I could describe it as spaghetti.
Yep.
So those connections were not tied together. They were misfiring.
Mm-hmm.
I had the memory of a gnat.
Yep.
Maybe they've got better memories, actually, to be quite frank. So my short-term memory definitely went.
Yep.
And I see that often when people are getting divorces. Their memory just goes. Their short-term memory.
Yeah. I mean, you're in a moment of distress. There's a change. There's a shift in your routines and your life, and you're going to be emotionally impacted by something like that, like a divorce.
Yeah. Yeah.
Any change in our lives can shift that. So those, I call those little T traumas, but sometimes those are the ones that are, like you said, that little extra sand that just push and the whole thing comes down.
Yeah. And it's catastrophic. Yeah.
Big
what
time.
I'm curious to find out about, so can you tell the difference when analysing a brain between big T trauma and CPTSD, for example?
From experience, they light up very similar.
Okay.
There's not a major difference. What I have seen is people who have experienced big T trauma and they've gone through therapy. Those areas are not as active, but they're active. The pattern, you can still kind of see it. So when you do tell them, hey, there's still more to work there. Some of those people are like, well, no, I've already done what I think I need to do. So my answer to them is, well, if you do face later another little sand, everything can come back out.
Yeah.
So
re-traumatization. I don't think many people talk about this actually, but it's very common. I think we all talk about trauma, we all talk about healing, but we don't talk about re-traumatization. And it can really disrupt.
And it shifts everything again. And it is frustrating. I totally understand. And when they tell me, well, I've done therapy for 15, 20 years, don't send me there again, and I'm like, but you see your response right now? Because when you do trauma therapy, it is kind of like removing that Band-Aid that is rotting that wound. So it's hurting. So if you're already giving me that kind of reaction about it, they're still there. And it correlates with the symptoms that you're coming to me today. So it's still there. It's still in our nervous system. Not everything is a pill or a supplement. You have to prepare the body to go through that healing process once again. Your body still feels attached to that moment in time. Your brain is very much attached to that moment in time. This is why you keep waking up every day at 2:30 a.m. Something must have happened that is keeping you up exactly at 2:30 a.m. every single night.
That's right.
The brain
thinks there's a tiger in the room.
There's a tiger in the room.
From it, it's not safe to sleep.
Mm-hmm. So it's those things that, when a person is re-exposed to another big T trauma or any kind of traumatic stressor, those areas light up again. We go back on that mode. So I just tell them we got to get back on that horse.
Yeah, the memory gets bad again.
Mm-hmm.
Spaghetti comes out.
Spaghetti. I like that visual.
Yeah, spaghetti brain. One of my friends called me Sivhead Guru because I was incapable of remembering stuff.
Yeah.
When you get people who've been traumatized, okay, so you're doing the scan, then you're giving them the news. What other therapies do you use? Is it a combination of therapies? I love the fact that you've mentioned body, because the body is integral as well. It's fundamental in helping to release trauma and to process and all sorts of different stuff like that. But what's your kind of go-to therapy initially to help a person?
Yeah. Initially, I do use EMDR a lot. But it's only if I see a hyperactive occipital lobe. So the occipital lobe processes visual memories. So that's another part of another pattern that I see in the scans, where it's more of like the exposures, the traumas that we saw and that we witnessed. And it might not have been done to us. We might have seen abuse in our parents and we witnessed it. It was not done to us. Yeah. So one of my patients, he's 60, I think 63, he came to us because he couldn't sleep for many years, has tried every single medication out there for sleep and nothing works. So as we're talking and I'm looking at his occipital lobe was on fire. And I'm like, it looks like you have a trauma brain. And I know you don't remember anything, but I think you need to do EMDR. So I think he looked at me and was like, this guy's crazy. I have never experienced anything. I had a beautiful childhood, yada, yada, yada. I'm like, okay, well, that's what I think you should do. This is my treatment plan based on what your brain, and this is why you came, right? You want to see what your brain is doing. He comes to the first follow-up and I discover that he doesn't pee. He doesn't use the bathroom during the day, ever. So then he pees only at night. I'm like, okay, well, that's strange. No one has ever looked into that. Isn't that a little weird? I told him. And he's like, nah, my whole life I've always been like that. And in the last 20 years, I don't pee in my home. I pee at night. Okay, that sounds like a trauma response. What's going on here?
It felt safe to go to the toilet during the day.
Correct. So I told him, listen, you really need to do trauma work. We need to find out, we need to open that memory vault and cure that, because I feel that is very much connected to your current symptom. Anyway, so he doesn't come back until like 5-6 months later. I thought he left. Like, this guy's crazy, me. I'm not going to do anything. Blah, blah. But he did come, and he was able to discover that when he was about 6 or 5 years old, he was in a public bathroom and a man came in to assault him, but did not do anything to him. So that's the interesting part. He didn't do anything to him, but his dad came in and beat this man up like bad, right? Defending his son. But this little boy saw this experience. So that's why I tell people it's not necessarily something that had been done to you. You might not have assaulted, but you witnessed it.
Visceral trauma.
Exactly. So he was like bawling when he told me, he's like, and so thankful that I pushed him to do that. So it doesn't matter how old we are. Our brain can still heal. Our brain can still get better. And he did follow my recommendations, and he's doing great. He's sleeping. We took off all his sleep medications. He's urinating at the right time of the day. He's healed from that emotional wound.
It's so fulfilling. And the fact that he probably feels freer in his body. Presumably his hip flexors are a lot. Because he's not holding in all that tension.
Can you imagine all those years?
Well, that's the thing. I wrote in my book, when people are being potty trained, so it can stem back weirdly. When people are being potty trained, if you've got a parent kind of screaming at you, if you've like soiled yourself or, you're not doing well, and the child then can instantly, and they hold on because they don't want to upset the parent. Parents aren't, the parents are just trying to help the child. So I don't mean to say, parents are really bad or anything like that.
Yeah.
But just a simple little thing like that to a toddler can actually cause a sequence of events physiologically further down the line.
Right.
Very interesting.
It's about relaxation. It's just really fascinating when you see those and then the patient does what you recommend them to do. So EMDR is one of the big ones. And kind of visualization.
And for the listeners, what does EMDR stand for?
So EMDR stands for eye movement desensitization and reprocessing. So a lot of it is to desensitize these memories. I explain to people, we have to reprocess these events, and our brain has them kind of recorded and stored. And it's through some kind of visualization type of exposure therapy. So we were visualizing, I tell them we're walking through these memories, in your mind, but you have to do it with guidance. Don't do it by yourself. Someone has to do this with you because they're looking at your body. They're looking at your response. Right. And not everyone is a specialist. So I do tell them, make sure they are EMDR trained, but that they are focused. Their training is all trauma because EMDR has become very popular nowadays. And, everyone is at different levels of expertise. I'm not here to say anything about that, but it's not just something that, you just tag on in your resume. Like if you know how to do EMDR and this message is, I would say to all people out there who are training in EMDR, you have to be passionate about working with a trauma exposed individual and very sensitive to their response, their physical response, how they respond to stressors, how they respond to you when they show up, because they know they're going to be exposed through their memories, but they're going to be re-exposed. So I always tell my patients, let me speak with them first. Whenever you talk to anyone.
Put them at ease, because I think the first session, it's the fear of the unknown, isn't it? So I mean, when I've got clients coming to see me, the first session, at the end of it, they're like, oh, it was actually easier. That was enjoyable. Mm-hmm. But before it, when I'm like, tell me what size do you perceive your hands to be? And, just doing all the usual checks, they're way off. And it is because they are nervous, they're anxious, like what's going to happen?
Mm-hmm. There's a huge anticipation and fears. And I understand it. So when I tell the patients, I would dive into other therapies first, maybe some cognitive behavioral, maybe some somatic focused therapies. Then you see if the therapist can evaluate you to see if you're ready to start going into that and you ease into it. So I always use the analogy of, I'm not just going to dump you in the pool. I'm first going to have you look at the pool.
Yeah. Look
at the water. Maybe touch the water. Yeah. Little by little, and then we go into the water. That takes time.
Yeah.
We're not just going to throw ourselves into exposing ourselves to these memories again, especially if they've been blocked. I have, great success when patients come back after doing EMDR with just several sessions. But the common response is, I have this thing just came off my shoulders.
It's a big weight.
I'm like, good, let's keep going.
Yeah. Yeah, I've heard many good things about EMDR. I know many people that have had it, and that it's said it's, transformed actually their health, physical and emotional. It's, it has been a game changer. So what other therapies do you use?
Well, cognitive behavioral, dialectical, somatic therapies. If there's any physical abuse, whether it's sexual or anything like that, dance therapy. And there's a few dance therapists who are trauma focused. You have to kind of reconnect yourself to your body in a different way. Just because now, that part of you or who you are was invaded. So if that's the case, we want to kind of navigate that again, but again, in a way that you feel safe, that you feel in control, because that's one of the main things about that kind of trauma that I've experienced with my patients is, in that moment in time, you did not have control of your body and you still feel that you don't. Now we need to regain that control. But that also takes time. We're not going to barge in. So dance therapy is a big one. Art therapy sometimes. So depending on the age of the person, equestrian, a lot of these that kind of connect your body to movement, is a big one.
Yeah. Yeah. It's about waking up the body, because trauma disembodies, doesn't it?
Mm-hmm.
Our head. I've had clients and I'm like, say hello to your toes. And, they've forgotten that they had them.
Mm-hmm.
Because that's just what happens. So it really is slowly and just kind of waking them up, but trying to also make them feel a bit fun And it's when the fun and curiosity comes back.
That's a big win.
Yeah. It is, isn't it?
A big win. Yeah. When they tell me like, I want to go watch a movie. I'm like, yes, go.
Yeah.
Go see Wicked.
Yeah. Brilliant film.
I'm like,
I did a reel on that.
Talk about trauma. That's a great movie in Hollywood. But as I tell them, like, I get so, excited. One of my patients this week, she is getting her license.
That's driving
huge.
Or
driving,
medical?
Driving license, right?
Oh, wow.
She was so fearful of just going outside, being on her own. And
that's huge.
She finished her degree. That was another huge thing that she was so excited about because of sensitive trauma. She stopped school. She's a writer, so she was able to do that. She was so proud to like show me her degree that she finished, her master's. And then now she's like, I think I'm ready to drive. And she never got her permit, and she's 27. She never got any of that. So I'm like, good. That's a sign of independence, of you being in control of your day to day of your life. So let's go. What do you need me to help you with? So those things are exciting.
It is interesting. And, but talking about control as well, what I've found is, I think when you've experienced challenging times and you felt really out of control, it can turn you into quite a controlling person. Right. Because that's your way of protecting yourself. Mm-hmm. So when I get people kind of shaking, tremoring on the mat, it's a real about trusting your body and allowing yourself not to be in control, but knowing how to turn it off.
Right.
And allowing them to get kind of softer and ease into it, and to know that they don't have to be perfect. There's no such thing as perfection. Right? Perfectly imperfect.
Right. Yeah, and I think it's a nice balance between control, but then trust.
Yes.
Because at some point, trust was really broken. And sometimes it's trust in humanity. The person that was supposed to protect you hurt you, that can happen.
Yeah.
But then I just lose, trust in people in general. So there is this disconnect and at the same time imbalance.
So we're heading to a kind of close of this session. I would love to get you back on, but what would you like the listeners to hear, considering it is the holiday season? And I think that can be really tough, for people who come from dysfunctional families. A lot of people with PTSD can have addiction problems, and there can be all sorts of different stuff like that. So what advice do you want to give them going into this season?
The holidays are not so jolly for a lot of people. It could be because the trauma is I lost someone. Now they're not here this holiday season. That's a big one. Another one is I'm now going to be re-exposed to someone who hurt me, maybe in my childhood, but they hurt me and that wound is still there, hasn't healed. Maybe I'm going to just have a very numbing season yet again because the whole year have just been numbed. And there's also this pressure, I think, by our society and social media to have this perfect holiday appearance, perfect table, perfect gifts, perfect life. We need to disconnect ourselves from that, have more control of our emotions, especially during this time of the year. But, I'm a big believer of planning. If you plan ahead, so if you're going to, you're going to go to that family party, that you're going to see that person, that is not, have a plan, have things that you're going to do to self-regulate. What are the things that usually help you self-regulate? If it means going outside for a walk, go ahead and do it. Do it. For that person that lost someone this year and I think the trauma of having Christmas or any kind of holiday meal, without that person on the team. Right? Well,
Yeah.
let's create memories with the ones that are there on the table. You know, it doesn't mean we're forgetting that person. By all means, no, please don't do that. But let's recreate new memories, because there might be now new people that are in the table this year. So we are hurting from that loss, but there's still someone now that I need to create a new connection and a new memory. Right. So if that means even creating a new tradition, don't make a dinner. Right? Go and have a late movie and do a potluck outside and put on a projector and watch a movie. You know, that I think we're so caught up in like, we have to do things a certain way during the holidays. And then the third one is the perfection, you know, like we don't have to do things that way.
No.
Create new memories, create new experiences. And it's really about connection, not perfection. Enjoy those people that are around you. And really just, you know, take this time to relax, to be with that person or that group of people that really bring you joy. And if it's not family and it's a chosen family, then have it with them, you know, but make sure you do form those connections and strengthens those bonds, because whether we've been hurt by people or not, we are social creatures. We need bonds. We need connection. And the very deep center of our limbic system regulates our bonding capabilities. So that to me, it says a lot of the core of our brain, right? About bonding.
Yeah.
And I get it if the bond has been broken in one type of relationship. Let's not lose hope of creating other bonds with other people that do want to be in our life and do want to enrich us.
And let's
So
get
that's really
some oxytocin flowing.
Yeah. And dance. Make sure you dance a lot.
Make sure you dance every day.
Yes, every day.
And when I go out, I'm walking, I've got my headphones on, I'm singing a good tune.
Dance.
Sometimes I even skip. And I know I look like an idiot. And people go, "You're skipping and you're 47.
Who
Yes,
cares?
I am. Do you know what? Because actually, it makes me happy.
Exactly. Dance is one of the prescriptions that I give all my patients.
Yeah.
And there was a period there where I worked with older people, and every person that I saw over the age of 90, I asked them, what is their secret? And they all said, dancing. And now I look at what dance does to the brain. There's so many circuitries that get connected and get excited when it hears music and dance. So dance.
Oh, I love that. Well, thank you so much for coming on this podcast. I would love to get you back on. But I've loved this conversation, and I hope that you have an amazing holiday period and you dance a lot.
Thank you so much for having me. And anytime. Okay. Bye.
You've been listening to the Brain and Body podcast with Allegra Foxlie. Thank you for listening, and thank you for your support.